because these are lifelong diseases and they need a long-term care. There are weak social protection, and many seniors face poverty, illness, which is a dangerous mix. And there are no long-term care models available. We improvise daily, and obviously, if on a daily basis you are doing this, that's unsustainable. So it's a flying blind. Without age-specific data or digital tools, we are just guessing and not saving. So this isn't just insufficiency, it's real lives in the balance, and we need to do something about it. I'm just trying to show you here about the international medical graduates in specialities in the USA. This is just to give you an idea when we compare it with Pakistan. That 51.2%, that is for of the international medical graduates in US actually go to the geriatric medicine. This is more than all the subspecialties that they opt for their training. But the situation in Pakistan is completely opposite. There is just a handful of geriatric specialists for over 16.5 million elderly people. There are only two formal pathways which exist. One in AKU, which runs a fellowship program in geriatric medicine, and there is a CPSP-linked, Birmingham-linked program in UK where they provide training. So this is the progress, I would say, but it's a single drop in the ocean of need. We need every medical college training geriatric experts, and we need every district hiring them, because the foundation is laid, and now we have to build on this by improving our systems. So how do we scale? With 4 non-negotiable pillars: education, clinical systems, policy, and research. If we invest in them, I think we can come up with something which can help us in the future. But we also need to know that UN has declared this is the decade for healthy and age-friendly environments, and that's our primary healthcare hubs and mobile units. So we have to combat ageism by training providers to value elders' dignity. We have to develop integrated care by linking clinics, homes, and social support. And we need to have a long-term care plan by piloting the community centers. So the Pakistan's action plans aren't optional, they are a global priority because UN also demands for this. So now let's build our plan to match the international standard. And we have to shift our focus on the health care instead of sick care. Unfortunately, we are treating patients and not preventing illnesses, which is the need of the hour. So prevention starts from the pre-geriatric care. So regular and moderate physical activity since childhood has to be encouraged. The nutrition services has to be improved. We have to tell our youngsters to abstain from smoking and alcohol and avoid self-medication. We have to engage them in healthy hobbies like reading, writing, sports, and listening to music. And in some countries, they have this financial security in adulthood itself program, which is an old age social and income security program with the name OSS. So we have to start in the pre-geriatric if we want to improve the care of our elderly. So primary prevention starts with health education. We need to improve immunization. We have to work on screening of chronic health conditions like diabetes and hypertension. We have to improve our dental services as well because they are also very important, especially in the elderly population. Exercise program, nutritional interventions, and in females and men also sometimes hormone replacement therapy is the need of the hour. Coming on to the secondary prevention, we have to screen for diseases like diabetes by doing a mass community level screening programs because diabetes has become the #1 disease in the adult population in Pakistan globally. We have to have mammography or ultrasounds of the breast for the early detection of breast CA, pap smear for cervical carcinoma, chest x-rays for lung carcinoma, fecal occult blood and sigmoidoscopy is recommended after certain age, especially with a family history for detection, early detection of colorectal carcinoma. Screening for ocular diseases, like if you have diabetes, screening for diabetic retinopathy or glaucoma, which is also very common in our population, and hearing evaluation. And these all come under the secondary prevention. Talking about tertiary prevention. So when illness strikes, recovery isn't just medical. It's just about restoring dignity we owe to our elders. So podiatry care, dental services, counseling, rehabilitation, this is all healthcare. So we have to invest in all of them in prevention and not in the cure. Geriatrics basically is not a single disease. It's about whole people with layered needs. And this is the 5Ms global model, which includes mind, mobility, medication, and what matters most, and multi-complexity. We know that old age is accompanied by multiple chronic conditions, advanced illnesses, and complicated biosocial needs. So this all has to be kept taken care of when we plan geriatric services. So I will just give few recommendations over here that what needs to change. PHC reforms. So age-friendly primary care and rural mobile units, they can be a helpful step. Then training the specialists, launching of formal geriatric programs because skills matter, and expand the Sehat Sahulat card-like programs covering home care, outpatient support, and filling the gaps. Then pilot the care centers, which is our community hubs for long-term needs, and we have to start locally and then expand. We have to invest in digital health, telemedicine for chronic diseases and mental health because technology saves time, and data system. We have to track the data, monitor access outcomes and costs, and this will help us in the long run. So geriatric team is not only doctors. We need to produce not only geriatricians, but nurses, physiotherapists, health workers, social workers as well. So I will end here by saying that investing in equitable, age-friendly healthcare systems in low and middle-income countries in particular is just not a moral imperative, but it's an economic necessity. So when we empower our older population, it enhances the societal well-being and it builds the resilient communities for future generations. So are we ready? My answer will be not yet, but we can be. Aging is a success story if we plan for it. This is a cross-cutting issue including health, gender, economy, and just not related to primary healthcare only. We must move from reactive to a proactive care model, and let's build systems that respect age, support independence, and promote equality. Thank you very much for it.
Thank you, Dr. Soumya. Very insightful information that we have to build healthcare, not sick care. And our primary healthcare system is not built for the CDs and NCDs and not for, rather for maternal and child health. So let's move on to Dr. Asif Imam. So in our mixed health system, NGOs and CSOs have been filling up a major gap in the primary healthcare service provision. You, sir, have been the pioneer of utilizing an NGO platform for delivering quality primary healthcare services through the SINA initiative. What are the challenges and the successes for CSOs and NGOs to deliver universal healthcare in Pakistan at national as well as provincial level? Or what innovations or intersectoral collaborations are needed to engage the NGO sectors to achieve these SDGs? And what is the public policy vacuum in engaging the private sector for UHC and primary healthcare?
Thank you very much. My name is Asif Imam, and although I'm an allergy immunology specialist, but my passion is primary healthcare. And actually, I moved from the US to set up a robust system of primary healthcare. So, as we all know, WHO says that 80 to 90% of healthcare needs can be met at the primary healthcare level. And if you look at Pakistan, we're just the opposite. We don't have any primary healthcare system at all. That's where the fundamental problem is. And this is what we need to address, that our foundation is actually not good. We don't have a good primary health care. The good news is that PMDC's new leadership, they have actually sort of revolutionized the thought process of what a good primary healthcare system should be. And they are now totally focused on primary healthcare. The leadership has understood that primary healthcare ke baghair kuch nahi hoga. So right now, PMDC is trying to revamp the curriculum in which the training of the graduates, postgraduates, because there was no primary healthcare training post-medical school. Everyone was training in the hospitals. And obviously, as you know, hospital training and the primary healthcare training is very, very different. So now what they're doing is they are mandating each medical college not to just open a hospital, but 5 primary healthcare centers for training of the students and residents. So this is revolutionary. So the trend and the intellectual process has already started. But the problem is that is the first step. So you have to change the curriculum, emphasize on primary healthcare, which will cater to 80 to 90% of healthcare needs in Pakistan. If you look at any effective healthcare system like NHS or the Canadian system, they have a very robust primary healthcare system. And this is where we need to focus and develop. So the Sinha story starts in 1998 when I came back from the US and started to understand the primary healthcare system in Pakistan. And obviously it was very obvious that we need to develop a whole system, not just do things in silos, complete system. And we presented our model to the WHO EMRO region in August 2023 as a care model of a primary health care. And it was well received over there. And since actually before we presented it, WHO has actually come up with 10 levers, operational levers of how a primary healthcare system should work. So what we have done is we have taken that 10 levers and we have developed our systems according to that. And I think we, out of 10, 9 of us, we can actually claim that we are doing that. So I think the first thing is you need a very robust model or a system with training. The doctors are trained in that system. The second challenge was you can have a nice infrastructure, a nice clinic, and the nurses, but the nurses and the doctors are not trained for primary health care. So we have to revamp the training as well. And this is a very big task. This is something that I think our PMDC is starting to do, but I think even the medical colleges and the residency programs should start doing. So the system is number one. Second is training of the multidisciplinary approach. Like we all said that our system is doctor-driven. It has to be multidisciplinary-driven. The doctor cannot do everything. They need a support team to support and provide the proper care to the patient. So training ke baad, basically it comes on implementation of that system with accountability. So हमारे वहाँ ये होता है कि आप डॉक्टर को आपने या नर्स को आपने एम्प्लॉय कर लिया and then कोई पूछता नहीं है कि उसका परफॉर्मेंस कैसी है. So this is something, accountability has to come. Until accountability comes, don't expect any kind of quality of care. So we have worked on that in our system also. We have started with the audits of the doctor performance, and we have a very robust quality performance audit system for the doctors, and we re-educate them. If they have any shortcomings, we train them. That's the third thing. The other thing is, this is age of digitization. We need a very robust 360-degree digital platform which will integrate all kinds of care. So we are in the process of developing a multidisciplinary digital platform, especially for primary healthcare, in which the doctor, the nurse, the nutritionist, the physiotherapist, the social worker, the pharmacist will have their own domains in which they can put their documentation of what kind of care they gave to the patient. So we have to move on to the modern technologies. And once we have done that, then we should work together, and then we come up with a national standard, like NHS. See, NHS is a national standard. We should work together, all the academic institutions and the NGOs and the private sector. They should come up with a national standard of primary healthcare, and then things are going to start happening. So that's my two bit.
Thank you so much, Dr. Asif. So a shift from the doctor-driven current model, accountability, digitization of services, and as we have gone through 4 of our panelists, I think all of them are agreeing that although there's 5 years left till 2030, but the primary healthcare has huge amounts of lacunae, and we are all aware of it. So we can definitely shift towards device policies to address them. Next, I move on to the primary healthcare systems, the public primary healthcare system specifically, and the maternal and child health services. So, Mr. Javed Jagrani Saab, who is the CEO of the PPHI, you have successfully expanded and improved the PHC network in Sindh, especially for the maternal and child health services. Please, can you share the public partnership model, this particular model, how it has evolved in Sindh, and how do you think that this model can be leveraged in our mixed health system to achieve the primary healthcare and universal healthcare coverage goals?
Thank you very much. Thank you very much. Yes, as far as PHC is concerned, with the perspective of this PPP mode, basically this public-private partnership, that's maybe if not that much new, but in the recent past, it's a new type of management model which has achieved good results in different sectors. So with this approach, government of Sindh applied this. Initially, federal government, all of the provinces, and then Sindh government, specifically in Sindh province, they adopted this approach in health sector and particularly in the primary healthcare side. So it really has brought good results and good fruits as far as primary healthcare is concerned, because I'll just briefly touch upon why it is so, because it is addressing system issues, basic issues with which our governmental public sector system was stuck up with. Why it was not delivering, why it was health facilities in far-flung areas were not delivering. So it basically, this new model whereby PPHI is working under an MOU with the government of Sindh, it addressed those core issues which were inherent in those public sector health facilities. Number one, financing model. The government of Sindh came up with under this PPP model. We have a different financing model whereby one-line grant is given to PPHI. It is PPHI who has to decide, who has to prioritize funding allocation. Before this, obviously was a different model, and prioritization was not being done. So this solution, this one-line single-line grant, really gave a space in terms of prioritizing the areas, geographical areas, services areas where by a true delivery can be done. Number one. Number two, then administrative independence. These were the two issues which were inherent, as I told you, as far as primary healthcare facilities were of concern of government of Sindh. So when I say administrative independence, here PPHI is totally independent to take administrative decisions in terms of HR hiring, in terms of aligning services with the modern day approaches and all that, which was missing earlier. So with these few but basic inherent issues addressed with this PPP approach, obviously there has been a topsy-turvy change as far as PHC is concerned. So once I share the results, I have maybe data when PPHI started some around 14 years back, few of health facilities were handed over by government of Sindh for its management, and right now the number is 1400 plus, which means in terms of the coverage, we are managing 40% of primary healthcare as far as population is concerned, the whole of the Sindh. And in terms of rural Sindh, we are covering more than 60% of primary health coverage. So we basically came up with a new idea with same issues, and the coverage is day by day increasing. Geographical coverage is increasing, whereby PPH is operating in all far-flung of areas of province of Sindh. Maybe it's tough areas, hard areas like Kashmir, Tharparkar, Kambar district. So we are everywhere in the whole of the province. In terms of financial coverage, analyzing services being given by PPHI vis-a-vis UHC, this is another important component of UHC, that in terms of financial equity, financial facilitation, the UHC services have to be provided, keeping the financial position of the patients also. So in their terms, PPHI is providing 100% all the services free of cost, which means addressing this particular issue of UHC. In terms of services coverage, we are focusing upon all the indicators which are covered under universal health coverage, all the priority indicators, which happens to be 30. In majority of the indicators, the PPHI is providing a comprehensive and 100% package, which happens to be around more than 40 to 45%. Around 30% of indicators we are giving partial services, and there are still 15 to 20% of indicators as far as UHC is concerned, whereby PPHI is not providing those PHC services. And obviously it depends upon government house, and we have taken up this particular case with the government house, and so that a comprehensive package of UHC is provided to the population of government house. Having said that, the good thing is we have, like, government of Sindh has piloted one project at Tanduwala, whereby a comprehensive EPHS project and package has to be given at Tanduwala. That will be pilot, and the target is that the UHC coverage in terms of essential package of health services has to be comprehensive. All those indicators, the priority indicators in terms of service delivery at PHC health facilities has to be, the target is that all those priority services are given to clients, to patients at the health facility level. So this is really a good start, whereby we are going to digitalize services. We are making the service package more comprehensive. So in winding up my discussion, I will just say that obviously this PPP this novel approach has worked as far as primary healthcare is concerned. Number one. Number two, more efforts are required. Obviously, if the package has to be comprehensive, Sindh government, and we are negotiating with Sindh government, more health facilities, maybe 100% of primary healthcare health facilities have to be given to PPHI, and once that is done, hopefully this whole UHC package will be comprehensive in Sindh. Thank you.
Thank you so much, Javed sir. So administrative independence that comes with the public partnership model has been very successful in Sindh, and if we look into this model, it could possibly be something which we can utilize, and other provinces can also utilize this model, which is solving some of the key issues and being able to administer the 3 pillars of the universal health coverage. So for the second round, we have identified all these problems, and I think we are all agreeing to it with all your expertise. We all know what the problem is. Now, if you can all just give us 2 to 3 solutions or recommendations, what should be the direction of working now in this time constraint of 5 years, trying to achieve universal health coverage through primary health care? Just 2, 3 recommendations from each one of you. Sir, aap se pehle.
Thank you. One thing I think we must keep in mind is that universal health care is not a luxury. It is a right of every child that is born, irrespective of caste, creed, or pocket, or whatever. So far, whichever model you look at, private-public model in Sindh. This is not really a private-public model. It's more of a philanthropy-driven model. That you have people, because there are more industrialists in Karachi and in Sindh, and there are very, very rich people and too many poor people. So there are very good people who want to donate something to for the base of the pyramid. So that is being, I think, used. But if you go to the rural Sindh, which I have myself gone to rural Sindh many times, I think the coverage there is, nowhere near that we need to be. So I think the universal health care in Punjab, they have tried to outsource it to the private, and they failed miserably. One thing the government must realize or be made to realize is that it is the responsibility of the government and not anybody else. So you cannot, provide universal health care or optimum health care to people with charity. Charity is add-on. You cannot shift your entire burden of your duties to the philanthropy center. You can only thank them for doing what they are. But they are not responsible. It's the government who is answerable to the people in what they have done. Unfortunately, I think what needs to be done is that we do have in Punjab, and I am in Sindh, rural health center, basic health units, but most of them are dysfunctional. They need to incentivize the human resource for health to go into these rural areas. Then they need to pay them double or maybe triple of that. So they need to populate that. Those buildings are now being used as, so somebody has started a school there or somebody. So they are not really functional at all, majority of them. So I think to make them functional, the main bottleneck is the human resource for health in these far-flung areas, the security issues, which again it's up to the government to sort out there, and then non-functional equipment there. So and then the provision of medicine is not there. So that needs a good governance model. In Punjab, we have a model where primary health care is separate and tertiary care is separate, specialized care. It didn't work. I think it was much better when we had one health department. The most important thing I think that needs to be done, and during my tenure as a minister, we started that, is the referral system. If you have a referral system where you have catchment areas with your tertiary care hospital, the teaching hospital, and then because they are also public sector organizations, then shift the duties to them to make sure that there is adequate human resource for health, like for universities, medical universities, health universities, or for the medical colleges. We did a pilot where we attached few districts to a particular medical college, like Allama Iqbal Medical College, and then the consultants were going there weekly to the basic health units, and even surgeries were started and everything. But as always, once the government changes, everything changes, unfortunately. So there was no sustainability, but the pilot did very well. 2 years pilot in these districts, Saiwal and Okada, attached to one medical college, and that improved the situation there, the vaccination rate, the nutrition, which is a problem in children, as Khalid Shafi just highlighted. And these things, our problem is there is too much overcrowding. For example, I have been chief executive of about 1 dozen major hospitals like PIMS. In PIMS, which is a university teaching hospital, we were doing 250 plus deliveries every day. So we are not a maternity home. So that is why I think the people look up to these tertiary care hospitals, because there are non-functional facilities next door. So
Right.
that they need to be made functional.
ठीक, thank you. So 2 minutes में what should we do? क्या करें? 2 चीजें 3 चीजें क्या करें?
I will just add to what Dr. Javed has mentioned. Actually, our priorities should be focused toward the prevention. That is the only way we can get the universal health coverage. And the missing part is that all the attention is on the curative medicine. Even preventive medicine is not much taught as it should be in the undergraduate and the other curriculum. And in the primary healthcare, the missing part is the community engagement. And the community participant is still in the places where it is practiced. The community engagement is not there. In the Azad Jammu Kashmir, the community engagement is so strong that their 85% vaccination is done at the vaccine centers. The community is so bound that they do not miss any vaccination. Their coverage is more than 90%. But in the other parts, it is only 30% vaccine is done at the fixed center, while the vaccinator has to go door to door. So it's a community participation which is an essential part of the PHC.
Right.
It should be promoted. That is the way we can get good results.
जी Dr. Sobia, 2 things we can do.
I think the key is the prevention, and we have to start with prevention if we really want to have universal health coverage with VHC. And the prevention has to start from the school-based trainings, nutrition, vaccination, and just from the grassroots level. Secondly, build up on the frontline workers. So we have lady health workers who are generally giving population control advice or gynecological services. They can be upscaled to screening for diabetes, for hypertension, for obesity, because these are the rising threat of non-communicable diseases. Then better data and digital tools. I think it is the area of digitalization, and without electronic records, it's not possible to make our policies. And finally, I would say proper referral between the primary healthcare hospital and the hospitals. That needs to be smooth and recognized.
जी, thank you so much, Dr. Asif. What 2-3 things we can do?
Ji, I think if you really look at the theory, it is very simple. The problem is implementation. That takes time, money, and all that. So I think यहाँ बैठ के we can say कि ये कर लें, वो कर लें, but I'm afraid it's not going to happen. So I'll give you this simple, actually very straightforward principles, especially on the primary healthcare. And this is what I've basically learned from the WHO and working in the field. So you start at the basics. Our model of care is flawed. We need to develop a multidisciplinary, patient-centered, preventive model of care. Now that's very simple to say, but doing it is very, very difficult.
Sure.
So a model of care, we need to come up with a model of care which the private and the public sector agrees on and say, okay, this is what we want. Right now we have multiple models of care, and that's not going to work. Second is training is the key. If you have a system and you put in the current nurses and the doctors to run that system, it's not going to work. So you need a very robust, multidisciplinary, competency-based training programs. So it is task-driven. It's not theory-driven. What you need to do, you need to train on that. So for example, a primary healthcare team, like I mentioned before, needs a doctor, needs a nurse, needs a pharmacist, needs a care manager who manages everything, right? You need a clinic supervisor who does the administrative work. So these are a lot of things that we need to do. So training, I cannot emphasize too much on training.
Okay, thank you. Sir.
Second, how do you implement it? Implementation में आपने training दे दी और उनको employee लगा दिया, वो अपनी मर्जी का जो भी करना है. Accountability systems, that has to be there.
Sir.
And उसके बगैर आप quality दे ही नहीं सकते.
Great.
You know,
Thank you so much.
standardize quality of care. You need to audit that. You need to monitor it. If someone's not following it, they have to follow it.
Thank you so
Right?
much. Ji.
Implementation. The other simple things is WHO has actually told us how to do it. So there are 10 operation levers of a primary healthcare center. You can just adopt that and implement it. And they're telling you how to do it.
Sure.
Right?
Sure.
So the solutions are there. We just need to get on it.
To implement.
Right.
Thank you so much, sir. Dr. Javed Saab, just 2-3 things that we can do, and then we'll wrap up this session.
Thank you. I have more thing to offer, obviously, because since I am dealing with the PHC, and mainly all have been touched upon by my senior colleagues. Very importantly, increase budgeting towards PHC, as was mentioned by Dr. Khalid, because to prioritize PHC, the percentage of budget has to be increased. Infrastructure development, obviously, we are still lagging in the infrastructure. We don't have updated infrastructure who cater to the needs of modern the PHC demands. HR strengthening, very important. Dr. Asif has mentioned that training is very important, because without strengthened HR, we can't do it, and we have to incentivize, as has been said by Dr. Javed. What PPC has been doing, like we have introduced third allowance at Tharparkar district, which is a very handsome amount, which is equivalent to one additional basic pay, and it's attracting doctors even from Karachi. Quality of care is very important. Continuous adaptation to modern protocols and standards, that's very important. Community engagement, because PHC can't be comprehensive without community outreach and without intervention for behavioral change. It's very important. Referral system was mentioned by Dr. Khalid, very important, because obviously PHC can't cater all of the services. So a robust referral system can save so many lives, and it can evenly shift the balance between primary healthcare and secondary healthcare. Finally, last not but the least, that is digitalization of the service, because without profiling we can't proceed. Very important in this modern day AI-based world, we have to digitalize services.
Thank you so much, Ji. So with this, we close our session with these esteemed panelists. And the wonderful part is that they all agree on the similar points that we need to do to achieve the universal health coverage in the primary healthcare SDG goals. With this, we would like to ask if there is any question from the participants, or we have time for one or two.
We have to. I'm
Two questions?
really sorry. Some questions definitely they would have been there.
Okay.
But
we want to wrap up the question. Okay.
May I request Professor Aftab Mohsin to please join us on the stage? Actually, Governor Sindh is on the way.
Okay.
Actually, he has reached. So we would like to distribute the shields, and then you have to.
Can I just thank them?
No, you can thank them. And
आप लोग प्लीज stay seated. Yeah. Thank you so much, Abid Saab. अगर आप के further हमारे guest or chief guest are coming, so we will just modify this end of the session. Sir, please have a seat here. This session, and I'll hand it over to Abid Saab.
Ladies and gentlemen, I would now request Professor Aftab Mohsin, President PSIM, for giving away the shields to our esteemed panelists. I would also request Mr. Zuhair Nasir, CEO, Badar Expo Solutions, and Dr. Abid Abbas Sheikh, Organizing Secretary, Healthcare Expo, to please join him up on the stage. Dr. Zainab Hassan, Professor Javed Akram,